Dear colleagues, congenital hip dislocation is one of the most important and challenging topics in pediatric orthopedics. In our research, we are trying to reevaluate the conventional treatment of hip dislocation in order to find the most personalized treatment protocol. My name is Gyula Domos. I work as a pediatric orthopedic surgeon at Semmelweis University, and my vision is to ensure the highest quality treatment for our pediatric patients and also to build one of the best pediatric orthopedic centers in Europe in 10-15 years. In order to achieve this aim, we have to introduce the best available treatment methods in every field of pediatric orthopedics, and we also have to work out new treatment protocols. My current research fits well into this concept. In the first part, we are investigating the risk factors of failure in the treatment of congenital hip dislocation. Based on a systematic review and meta-analysis, we would like to define how we can reach the best results and avoid complications. In the second part, we are analyzing the results of our treatment protocol at Semmelweis University, which is different from the international protocol, but we seem to have better results with it. Because of the high amount of data and large number of publications, we divided the first project into 3 topics according to the different treatment steps. So let's see how the first 3 projects join each other. According to the international protocol, after a failed conservative treatment or in case of late diagnosis, a close reduction of the dislocated femoral head is performed under general anesthesia. If the close reduction fails, a surgical open reduction is needed. If the open reduction fails too, additional surgery, femoral and/or pelvic osteotomy is performed. But complications are quite common with this treatment protocol. Unsuccessful reduction and redislocation are the main reasons for failure. In addition, the most serious complication of the treatment, the avascular necrosis of the femoral head, is common too. The overall rate of it is 10% in closed and 20% in open reduction. What we don't know is the rate of failure and the risk factors of failure. But if we could identify the cases where the conservative treatment will probably fail, we could skip the conservative step and perform a close reduction immediately. Thereby, we could avoid several complications and unnecessary interventions. If we could select the cases where the close reduction is likely to fail, we could skip the close reduction step and perform an open reduction. And based on this scheme, we could perform a primary complex surgery if the open reduction will probably fail. So our questions are, what are the risk factors and the overall rate of failure in the treatment of congenital hip dislocation? We are investigating 3 groups: patients with conservative treatment, with close reduction and open reduction, and the intervention is the presence of risk factor, and the comparison is the absence of risk factors. And the outcome is the rate of failure. Our hypothesis is that certain risk factors increase the rate of failure in the treatment of congenital hip dislocation. I performed a systematic search in last October with hip dislocation and reduction, and we found more than 12,000 eligible records and 200 eligible full texts were selected. These publications cover the 3 topics: the conservative treatment, the close reduction and open reduction group, and we found 68 publications regarding risk factors, and we also found more than 130 publications with data on rate of failure. Having decided to divide the first project into 3 topics, I performed a new systematic search in the topic of close reduction in July, and I found more than 100 eligible full texts in this topic. In the close reduction group, we found data about 5 different types of failure in the publications. The primary failure rate was 13%. This group consists of 2 subgroups. The intraoperative failure is when the dislocated head is not reducible in the operating room under general anesthesia and an open reduction is needed. The rate of it was 25%. And the postoperative failure is when only the postoperative CT or MRI scan shows that the first reduction attempt was not successful. But after a successful primary reduction, redislocation of the femoral head can also occur. The rate of it is 8%, and the overall rate of failure was 20%. We found in the publications and analyzed 68 potential risk factors, and we had 134 forest plots, and we found several significant risk factors which are marked with red dots on this summary plot. We found that the grade of dislocation significantly influences the rate of failure. In low dislocations, the rate of failure was significantly lower, and in high dislocations, the rate of failure was significantly higher. The odds ratio was, in this case, 17.45. And we also found that high dislocation was a significant risk factor regardless of the classification systems. And we also found another important result. The rate of failure was significantly higher in male patients. There are several strengths of our study. This is the first systematic review and meta-analysis regarding the risk factors of failure, and this is the most comprehensive meta-analysis in the topic of hip dislocation treatment. And we were also able to identify high-risk patient groups. But there are some limitations too. Publications do not consistently investigate and define the different failure groups, and the treatment protocol was not exactly the same in all publications. So the conclusion of our study is that the risk of failure in close reduction is high in high dislocations and in male patients. And in these high-risk patient groups, open reduction is advised instead of close reduction to avoid unnecessary interventions and other complications. But randomized clinical trials could clarify what other risk factors can influence the rate of failure in these high-risk patient groups. So I finished the first manuscript in the close reduction topic in December, and the target journal is the Bone and Joint Journal. This is a D1 journal in orthopedics, and the impact factor is 5.3. And I also submitted the abstract for the next year's annual meeting of the European Pediatric Orthopedic Society, and it was accepted as an oral presentation. In the two other topics, we almost finished the data extraction, but we didn't find any significant results in the open reduction group, and that is why we are planning to include the open reduction and osteotomy group as well, and we would like to analyze these two topics together. In our last project, we are analyzing the data of our results treated with primary complex surgery in our institution. At Semmelweis University, we don't use the international protocol of hip dislocation treatment after a failed conservative treatment or in case of late diagnosis because of the high rate of failure and avascular necrosis. During the treatment, we would like to avoid the forced reduction of the dislocated femoral head because it can damage the blood supply and can cause avascular necrosis. As we cannot select the cases where the conventional treatment will probably fail, we skip the close reduction and open reduction steps and perform a primary complex surgery. Although we perform more surgeries than the other centers, practically we can minimize the rate of failure and avascular necrosis. So in this project, we are investigating the exact rate of complications and the late results. So these are the four projects that we are investigating. The next step is to complete the conservative treatment group and then the open reduction group, and finally the results of our treatment protocol. And I brought a quote from István Szepsi, who is a famous and internationally recognized winemaker. His verse that the highest quality is our moral duty is also a very important rule in medicine, especially when we treat children.
Congratulations, Gyula, for your presentation. My question is that you mentioned that it would be advisable to do a randomized control trial for the patients who have high dislocation and male patients with a bigger risk that the conservative and the close reduction might lead to failure. And my question is that what is the main risk of the open reduction? So if they are selected to these studies, what should they expect?
Thank you for the question. I think we should, or somebody should, perform the clinical trial in only the high dislocated group of patients. So in the ICD grade 4 and Tönnies grade 4, these are the high dislocation grades. And I think there are some data about that in bilateral dislocations, if both hips are dislocated highly, the rate of failure is 94%. So probably, so we should or we have to select the cases in the high dislocation patients, maybe in female patients in unilateral hips, the failure rate is lower, and in, for example, in male patients, highly dislocated patients, bilateral dislocations, the failure rate is almost 100%.
First I have a comment because I was just thinking of my previous question that this is why what Peter is generally saying, that this is why we need good quality data, because of course I know all the studies because we were working on this together, and what I see is that none of the analysis was looking at all type of risk factors or every risk factors that can be considered, and based on that, based on the selection to have a combination of risk factors, when you can say for 100% sure that don't do this intervention because 100% it will fail. So that's one, first of all, this can be analyzed from a very good prospective cohort with all the possible risk factors. First of all, and I have a question regarding the potential bias in our results, because of course the first treatment choice, as I know from the project, is to do the conservative way. Some of these will fail, and therefore they will go to the other possibilities. However, a lot of them, or what percentage of them, will succeed with the conservative?
We don't know yet the overall rate, but it is from 0 to 55%. So approximately 15 is the overall rate, but we haven't finished.
15, so but it's really low then actually,
yeah.
So that's quite low, and only those small percentage of patients will get to the next step and the step after that. So we will see a selected population, and not the general hip dislocation patient, but only a selected one. And that's why I'm saying that also we have to consider maybe this part. Maybe we don't have to add this to the article, so let's finish it as quick as possible because you are at the end of the writing. But let's consider this, what selection bias can we have, because you also had this plan to check what is the failure rate and the risk factors for conservative treatment.
Yes, but in case of late diagnosis, the first step of the treatment is the close deduction. For example, in Germany, late diagnosis means if a child is detected over the age of 6 weeks. And in England, the late diagnosis is the age over 6 months. So in Germany, in a 2-month-old patient, the first step is the close deduction, and they do not attempt the conservative treatment.